Assalamu alaikum. We are starting our today's program, and this is our third webinar. And today we have our guest speaker, Dr. Abid Saleem. He is associate professor and head of department of Gamma Knife Radiosurgery Department at Do International OJA campus. Uh, he has vast experience of this Gamma Knife Radiosurgery. So we welcome you, sir, and over to you, sir, uh, to start.
जी अस्सलाम वालेकुम
Walaikum
डॉक्टर
assalam, sir. Thank you so much, sir, for joining. Jazakallah.
जी डॉक्टर Aziz, I appreciate your efforts because you know what young neurosurgeons need in their learning and propagation. So this is very good initiative. I really appreciate that.
Jazakallah.
Next.
Sir.
Next.
1 minute, sir.
So our learning objectives in this webinar are that will give you a short introduction, then the main principles of radiosurgery, the medical physics related to this, radiobiology of radiosurgery, and then what are the different current available platforms and devices, how we do dose planning on these systems, what is the delivery, the treatment, and the workflow, then the indications, their outcomes, and finally, the complications and safety procedures. Next. So this is the cases presented in this webinar from my personal series. I started the work on radiosurgery since its inception in Pakistan, which was in 2008. And till then, I have done more than 6,000 cases of various brain lesions, and almost all the available indications we have been treating on this platform. Next. So radiosurgery is a non-invasive therapeutic modality which we use to treat brain lesions. And what it does during this radiosurgery, we focus a ionizing radiation to a specific target within the brain, at the same time saving the healthy tissues around that target. Next. So the basic principles are high precision and accuracy. That means that delivering the dose within 1 millimeter of the intended target, high dose conformity, minimizing the dose to normal tissue, steep dose gradient, which means that rapid dose fall off at the periphery of the target. So this was the first lesion which was made by gamma knife in the brain in an experimental model. And you can see this graph that here the 100% of the dose is deposited, and here the 50% dose. So there is a very sharp fall off from 100 to 50. So the maximum dose is concentrated inside the target. Next. So we use the principles of stereotactic localization, which I think in the previous lectures, Dr. Aurangzeb and Dr. Kashif Sultan have been explaining to you what is the stereotactic localization. And in this, we use three-dimensional Cartesian coordinate system on the MRI and CT scans, which we have been acquired. So this allows us to achieve sub-millimeter accuracy. Next. Previous one. So this is the Cartesian coordinate system in which if we do an imaging according to this framework, in which we apply a fiducial system, a fiducial setup, a frame to the skull, and then we take the imaging, then every point in this space has an XYZ value, which the computer uses to localize that point. And this same system has been used in radiosurgery and previously has been used in deep brain stimulation and stereotactic biopsies. Next. So some historical review. This is Professor Lars Lexell who started this idea. He was a neurosurgeon in Sweden, and he was very much disturbed by the mortality and morbidity of neurosurgical procedures at that time. So he wanted to do minimally invasive procedures in the brain. According to him, he wanted to decrease the sweat, blood, and tears in this specialty. This was in his own words. So what he did at that time, it was the beginning of stereotactic system formation. Various people in various countries were trying to do and achieve the stereotactic frames. So he made his own system. And the beauty of this system was the center of arc principle, that if we apply this arc, then if you enter from any point in the skull, it will reach the same target. Next. So this is the more
السلام عليكم.
Islam.
بدأ
So this
بدأ
this is the graphical system
بدأ
presentation in another view, and is his hallmark paper on this system. Next. So this is how the center of arc principle works, that for entry from any point will focus on to a single target. Next. And using the same arc, he devised the gamma knife device in which the same center of arc principle was used, that if you keep your sources of radioactive force sources in a hemispherical pattern, they will all focus on one point. Next. So what he initially used, as is shown in a previous picture, the ortho voltage X-ray tubes to focus the radiation onto his targets. And later he used and experimented with various available devices at that time, like linear accelerators, proton therapy units, and other things. But he finally made his own system, which you can see the first prototype, in which the radioactive sources are placed in a hemispherical pattern, and they all focus on one point where you want it to. And what I understand from his uh, historical perspectives, that he wanted to make a device in which the neurosurgeon can work on his own, and he has to be least bothered by the intervention of other specialties in this thing. So the gamma knife, if you started work on this, once you have learned the procedure, you will be able to do the whole procedure from the start to the finish as a neurosurgeon on your own. Next. So this was the first prototype, which made the model B, U, C, perfection, and then the icon, and now the spirit. So this is the evolution of gamma knife from 1968 to date. Next. And this is the gamma knife icon which we are using here at Dow Gamma Knife Center in Karachi, OJ campus. Next. And the other platforms which we'll discuss later in the webinar, how you can use the linear accelerator, the miniature linear accelerator in CyberKnife, and the proper linear accelerator can also be used with this technique. Next. So we take a break from the hardware, and we'll discuss some basic points of basic sciences involved in this technique. So the gamma radiation which you use is a form of electromagnetic radiation that is central to the function of gamma knife radiosurgery. And understanding its fundamental properties, sources, and interactions with the matter is essential to grasp how this technology achieves this therapeutic effect. Next. So what are the gamma rays? They are highly energetic photons, typically in the range of kiloelectron volts or even to million electron volts. So these photons are emitted by a radioisotope, which is the cobalt-60. And it allows, this high energy allows the gamma rays to penetrate the tissues and interact with the deep-seated structures and makes it very suitable for intracranial procedures. Next. Cobalt-60 is a radioisotope of cobalt, which has a half-life of 5.2 years and is very stable and is very easy to use. And it is actually housed in small shielded capsules, which I show you in the next slide. Next slide. These, you can see these small pellets on the slide. They collectively, weight only 5 ounces, but in order to do the shielding for this radioactive material, 44,000 pounds of steel is required to shield these radioactive sources, and the collimators are used to focus this high energy radiations to a single point. Next. And how these rays interact? There is the medical physicists, they have investigated. One is the Compton scattering, second is the photoelectric effect, and third is the pair production. So all these methods, they actually knock off the electrons from the atoms in the tissues in which we are directed, in order they will change the molecules or which these atoms are a part of, and we will reach the result which we required, and that is shown to be by the radiobiology, which is our next topic. Next slide. Yeah, I think this during the transmission from here, the slides have been, but I will tell you, this is radiobiological events involved. Next slide. So there are two things occur when these rays interact with the tissues. One is the direct damage, and second, the indirect damage. So what is the direct damage? That these high energy photons, they directly interact with the DNA and causes either the single strand or double strand breaks. So it will disrupt the integrity of the DNA, and if the cells cannot repair these damages, there is destruction, deletion of these cells. Next. And what is the indirect effect? Previous slide, please. The indirect effect is that the radiation affects with the water molecules in the cell, and they generate the reactive oxygen species, ROS, the hydroxyl radicals, which in turn damage the DNA, proteins, and lipids of the cells. So the extent of DNA damage determines the cell's fate, leading to either apoptosis, mitotic catastrophe, or senescence if the repair mechanisms fail. Next slide. So the cellular effect are either the mitotic death, which is the most common in the tumor cell. The damaged cells attempt to divide and they failed due to chromosomal instability. Then there is apoptosis, particularly relevant in radiosensitive tumors like lymphomas and germ cell tumors. And one other important thing is vascular endothelial damage. The radiosurgery, the radiations, they damage the endothelial of the abnormal vessels, particularly the AVMs, and which will lead to vessel occlusion over the weeks onward. But even in tumors, when their blood supply is disturbed, the necrosis of these tumor cells occur. Next, please. So how the radiosurgery and the conventional radiotherapy is different, we need to know very clearly. So various differences I enumerated. In radiosurgery, we give very high dose, while in radiotherapy, they give low dose, like 2 gray per fraction. In our cases, we do either 6, 8 or up to 25 gray per fraction in various, depending on the diagnostic setup. So how radiotherapy achieves its effect? That when you radiate in conventional radiotherapy, they give low doses over a period of few weeks. And what it does, that it will affect both the normal tissue and the abnormal tissue, that is the tumor cells. But the tumor cells have less capacity to repair from the DNA damage. So this differential is being used in the radiotherapy, conventional radiotherapy. But in radiosurgery, what Lars Lexell has this idea that if we target our radiation to only to the tumor cells, then we can give a very high dose because we are only targeting the tumor cells. And that will achieve very quickly the radiation effects on the tumors. Even those tumors which are resistant to these low dose radiations can get an effect. So that is why even in benign tumors like meningiomas and acoustic schwannomas, we can achieve this destructive effect of radiation, which we were unable to do in conventional radiotherapy. So in this radiosurgery, we either use single fraction or up to 5 fractions, while in radiotherapy, they use 30 to 35 fractions. In radiosurgery, we use a lot of beams. We are focused on single point. Here, they only use few beams. And accuracy is more obviously in radiosurgery. And the intent is tuber ablation in radiosurgery, while it is not the usual attempt in the conventional radiotherapy. Next, please. So various radiosurgery platforms, like we have gamma knife, cyber knife. Then there are the linear accelerators which have been modified to be used on this technique. And then there is proton radiotherapy. This we need to know that all these other platforms are the mimics of the gamma knife. When the gamma knife succeeded in doing the radiosurgery, the various other persons tried to mimic this technology in other platforms. Like in CyberKnife, it was made by John Adler, and it was a student of Lars Lexell. And what he wanted to do, that he wanted to use the same technology in other parts of the body also, to achieve the same success that we have achieved in intracranial procedures. They wanted to use it in other parts also. So the cyber knife can be used in extracranial lesions, also using the same technique. The same is true for the linic-based radiosurgery, that this technique can be used in the popularity has gone to the body, so they are using it for stereotactic body radiotherapy. Then there is protons, where they generate proton beams and they use the protons instead of the photon quantas. The advantage, they say, in protons is that the Bragg peak effect, that when you target the protons in somewhere in the body, the proton effect reaches to a maximum at certain point from the entry and then disappears. So there is no exit radiation in the proton things. We'll talk about it more in later. Next, please. So what are the advantages? The gamma knife had the advantage that with the intracranial precision is the gold standard. They achieves the steepest gauge gradient and ideal for functional disorders also. And this is the platform in which the neurosurgeon drives it from the start to finish. And the other thing is that we are using the dose planning directly on the MRI images. So you see all the CyberKnife, Linac, Proton, they plan their treatment on the CT scans. They cannot directly plan on the MRI images. Therefore, they have to depend on fusion technology of using MRI images with the CT and then planning on them. So while in gamma knife, from the very earliest models, we can directly treat the MRI, the tumors on the MRI images, which was very much needed in intracranial lesions because we wanted to save every inch of the brain tissue, which is only possible with the planning of the MRI images. Next, please. So the limitations are that gamma knife is what we can only use intracranial lesions, not even in the spine or elsewhere in the body. While the cyber knife, which was actually made to use this technology in other lesions of the body. Linic also, uh, but you see that the steep dose gradient which we can achieve in gamma knife cannot be achieved in other platforms because the cyber knife has a very moving entry. Linear accelerator based, the source of the radiation is very far from the targets, so that precision cannot be achieved in linear based. And proton therapy is although is very expensive, but till now it has not achieved the outcomes which we can say are extraordinary from the other techniques. So this is also very little advantage it gives, but is very it as compared to the expense involves in this technology. Next, please. So there is no equivalence of these techniques with the gamma knife. You see, this is if you search on the PubMed, the publications of gamma knife you can see is up here. And publications from other platforms for the intracranial lesions are down there. Next, please. This is the breakup from the various year-wise. You can see the publication, the research work on gamma knife is in thousands and is very less in other techniques. Next, please. The other thing is the radiation protection for the patient. Because they are like in cyber knife, they're actually using a miniature linear accelerator. So they have to compromise on the weightage. So when they compromise on the weightage, they have to decrease the shielding. So with the use of cyber knife, the rest of the body achieves a very high dose of radiation as compared to the gamma knife. The same is true for other technologies also. So the exposure of the rest of the body is too much in other technologies. So much so that because we are using a very high dose in single session, if we try to use the single session in other platforms, it becomes very dangerous. So even the NHS in England, they have issued a warning that the other platforms, if they are using for radiosurgery, they should not be used in children. Next, please. And even in the brain, you see, this is a plan from the gamma knife, and this is a plan from the linear accelerator, and this is a plan from the proton therapy unit. You can see the steep dose gradient which we achieve in gamma knife cannot be achieved with the other special platforms. Next, please. Here again, the gradient index, which means that how much the steep dose gradient we can achieve. The gamma knife is here, and while the rest of the platforms are way far behind. Next, please. This is a treatment plan for multiple meds. There are about 44 meds have been treated in this patient. You see that the dose of 18 to 20 gray are used in the meds, while their whole brain has received this purple cloud is actually 3 grays, which is just one dose of conventional radiation to the brain, 1 day's dose. In the single session, you can achieve the targeting of multiple beds by the gamma knife, which is not easily possible with the rest of the techniques. Next, please. So now we come to the dose planning and delivery part. So I will tell you about the latest gamma knife icon which we have at OJA. Next. So this we have all talked about that there are the sources in the hemispherical pattern and they focus on one point. This is the basic principle. Next. So the other thing which we need is immobilization of the patient. So previously on gamma knife, which you are using only the frame-based technique, which was this. But now we also have the option of putting in a mask. This is a mask is made for, especially for a single patient. And it when we applied it to the patient is so much immobilized that we can achieve our target. Next. So the other thing which is very beneficial in Icon Gamma Knife is the cone beam CT. This CT, cone beam CT, is available on the device. And the other thing is high definition motion management, which we use while we are using the mask technique. Next, please. This is the artistic proposition of the cone beam CT. Next. When it goes around the skull, you achieve about 200 images, which we can be remodeled into the image, which we achieve. Next, please. And the good thing about the CBCT is it is not only giving us a CT picture of the brain, but it's also stereotactic coordinates have been already applied to these image. So every voxel in the CT image, there is an XYZ value have been calculated by the computer. So if we co-register it with the MRI images, the MRI images also get these lexel coordinates applied to that. Next, please. So this is what we achieve when we have placed the patient on the gamma knife machine, and we have taken the cone beam CT. The upper three images are the cone beam CT, and the lower three images are the usual MR images which we achieved without any frame or mask. So with this co-registration, you can see we actually check manually also, although it's never bothered us. But you can see that all the points on the voxels in the CT scan has been co-registered with the proportional voxel on the MRI. Next, please. So we can use in the initial stage cone beam CT, or even if we need it at any later stage to co-register, we can do a repeat cone beam CT. Next. So these two techniques, the mask and the frame, both can be used. So why we use mask? Because with the frame, it's a single session treatment. So when we want to use a single session, we usually use the frame like a small target, like in trigeminal. We only need millimeters of our target, so the frame is a must. But if we have a larger tumor, which does not need so much localization, so we can use a mask, which is equally good, as I'll show you later. Next, please. And this is the motion management system. Infrared rays are targeting the patient's skull, and here is the receptors, which will give you a feedback to the system that if patient is static or should doing any movement. Next, please. This is another picture describing the same thing. And why we are using a mask? Because we want to use the multiple session technique. And why we use the multiple sessions? Because if the tumor is large or it is very near to a critical structure like optic nerve, it is not, and we think that it's not safe to give a high dose radiation to this target. We will divide the dose into 5 sessions and then treat the patient in 5 sessions. So our dose to the critical organ will be reduced and will be more in the safe zone. and as compared to the frame-based treatment which we usually do. Next, please. So, and this infrared system is very much in coordination with the delivery of the radiation. So, in this, which we call as the gating, is so precise. You see that we have told the given computer that this is the line. If the movements occur beyond that line, is not acceptable. So what he will do, that as long as the patient is below this line, movement of the patient is below this line, he will continue to deliver the radiation. Next, please. And as soon as the computer noticed that the patient has moved beyond this, the radiation will stop. And you will see that what is the thing which is bothering the patient, will communicate with him and restart the treatment once the things are settled. So this occurs within seconds. So there is no harm is delivered to the brain. Next, please. This is the inner working of the gamma knife machines. Here the patient lies, and here when it goes inside the gate, and here the sources, and it has been divided into various sectors of the collimeter, which are various size 4, 8, or 16, which we use as we show in the next slide. Yes. And this was the slide shows that this was the previous models in which the space was very less around the head, but in the recent models they have accommodated a larger space, which is very much more convenient. Next, please. So the collimeter system actually make us very easy to plan because what we wanted to do is to paint the dose on the target, and these spherical collimeters allow us to do that, which we can stop and use according to the requirement. Next, please. These are the collimeters, various sizes which we use repeatedly, and there are actually 8 sectors, each having 24 sources in one sector. So total are 192 sources. Next, please. Yes, if you press next, it will show you. Next, yes. So this is what when you all sectors are open, you see the red ones. The shape is like this. When one sector is blocked, the shape is like this. Next. So as you are closing the other sectors, you can change the shape of your dose paint according to the shape of the target. Next, please. Yeah, this next. Yeah. So with blocking of various sectors, you will ultimately achieve the dose paint according to the shape of the target. Next, please. And eccentric lesions was very difficult to do when I was working in the previous models. Anything which was very near to the skull on the one side, because we wanted to keep it in the center of the focus, it was difficult. But now in these new machines, the space is large enough that any eccentric lesion can also be treated very conveniently. Next. And anything which is even below the skull base, like this glomus jugular tumor is below the foramen magnum, can also be targeted. Next slide. Yeah, so you can see this even below the skull base, we will able to reach to this glomus jugular tumor. Next, please. So what another thing which is have been made in the gamma knife icon is actually, even if you have made a plan but the patient has tilted on the couch, you can tilt the plan according to the movement of the patients, which is called the virtual movement. Next, please. This was the original plan. Next, please. And this a rotation has occurred, but the plan also has shown the virtual rotation according to the movement of the target. Next, please. Yeah, this 5 degree and 2.5 degree. How much degree is needed? The plan will rotate. Next, please. So with this gamma knife icon, we can even treat a very small target, like in this VIM target or a trigeminal neuralgia, a few millimeters nerve, or we have a large volume, which we use the mask treatment for hypofractionation, treating it in more than one session, up to 5 sessions we usually use if the lesion is large. So both small lesions and the large lesions can be used. In this, we will use the frame, in which this we will use the mask, and this both things are not available actually in the CyberKnife or other linear accelerator platforms. Next, please. There are a few slides which we show that our initial 1,000 cases which we treated at the DAW unit. These are the various pathologies. Next. Age range 2 to 91 years, mean was 42. Next. Gender almost equal in both cases. Next. So either we use single session or multi-session treatments. Next. Both treatments have been used. Rest. So this is the various, either we use 2 fraction, 3, 4, 5, 6, depending on the target size and the diagnosis. Next, please. So here in this slide, you see that in vestibular schwannoma, meningioma, pituitary adenoma, metastasis, craniopharyngioma, the both techniques have been used, the frame and frameless. But in trigeminal neuralgia and AVM, we have to use only a single session treatment, that is the frame-based treatment. Next, please. Yeah, so now we will come to various clinical indications in which we are using gamma knife. So first start with the acoustic schwannoma. This is the pre-gamma knife. Next. This is after 6 months. Next. Next. And this is 1 year. So you see at 6 months, usually what happens, you will get is a central necrosis. And at 6 months, even in 5 to 10% of cases, there is actually the inflammatory reaction. So there is central necrosis plus some increase in the size, but the size actually regressed after another 6 months, like in this case, at 1 year, you see the regression. Next, please. Another case, similar reactions. Next, please. This is a long-term patient study which was available to us. We treated with 26.5 cc's, a large acoustic schwannoma in a lady. It was treated in single session. And you see over the years from 2010, 12, 13, 14, 15, the has been progressively reducing in size. Next, please. Another long-term study. You see a fairly large tumor with the distortion of brainstem also, but has shown a very good response. Next, please. Meningiomas in residual cases, deep-seated cases, cases which are near to brainstem. Usually we got these referrals, and this is a case for the residual, we recurred meningioma actually, and which we treated and regressed over time. Next, please. Cavernous sinus meningioma, surgery is difficult for these cases, but they show a very good response. This has been shown to a 6-month response, very nice. Next, please. This is the same patient, which is showing the coronal images. You see how much clear regression of the tumor has been achieved. Next, please. The same patient with the sagittal picture, very clear regression. Next, please. Another case of meningioma, the kind of extreme ones, which we see in 6 months. Or can you press again? Yes. Yeah, in 20 months, the later stage, you see only a small announcement is seen at 20 months. Next, please. There is another entity in this tumor which looks like cavernous sinus meningioma, but this entity has been labeled as cavernous sinus hemangioma actually. But on images it will look like the same like cavernous sinus meningioma. But when we treat them, we see a regression in 6 months. So we retrospectively call it cavernous sinus hemangioma because meningioma takes a longer time to regress. So this was cavernous sinus hemangioma regression in 6 months. Next, please. Petroclival, very difficult to treat surgically. This was referred to us and we treated with the gamma knife. Next. And you see the regression at 1 year. This is the at gamma knife and this is the regression in the coronal sagittal images. Next, please. Ependymoma. This was actually tried to be removed by surgery, but could only do a small part. Later, we treated with the gamma knife, and you see very good response. Next, please. Hypothalamic glioma, a centrally placed lesion which is difficult to treat surgically, treated with the gamma knife, and this shows a central necrosis at 6 months. Next, please. Craniopharyngioma is a very good target for us because of its location and its adherence to the hypothalamus and optic apparatus. It's very difficult to treat surgically when it is if it is attached to these structures. So this we have treated this at 1 year and this is at 2 years. Next, please. Yes, another case of craniopharyngioma, the sagittal views. Next, please. Yes, next. So this 3 months and 1 year. Next, please. This was actually tried surgically but could not remove. So it was the residual lesion, but it's still very large. So there was no other option. We treated it in 5 fractions, and you see very good regression at 6 months in a child. Next, please. Final lesion tumors also difficult to treat immediately, but usually they show a very good response. Next, please. Glomus jugular tumors, highly vascular tumors, and if we treat it with surgery, it's very difficult. It is incorporated in the lower cranial nerves. So usually they get referred to us and they show a very good radiosurgical response. Next, please. Next. Yeah. Non-Hodgkin's lymphoma, recurrence, they actually respond very well to radiation. Otherwise, it's a very lethal disease. But as for the brain, we can show a initial response is very good. Next, please. Pituitary gland, there are not. I could not upload many pictures because of the short time, but you see in pituitary, in residual recurrent cases, the pituitary tumors are very much responsive to radiation, and in non-functioning cases and even in functioning cases where you can get a very good response. A lot of patients with acromegaly we have treated, with Cushing disease we have treated, and we get both radiological regression plus the regression in the hormonal levels over a period of time. So for residual recurrent pituitaries, do consider gamma knife radiosurgery in your patients. Next, please. Another case of final lesion tumor, you see, it could be a germ cell tumor which shows a very rapid response. Even in few weeks, you see the regression of the tumor. Next, please. The T2 images of the same patient. Next, please. A recurrent hemangioblastoma. Our result has been 50%. When it responds very well, like in this case. But always look for a recurrence. They are more likely to recur also, even after the regression. Next, please. Recurrent nasal angiofibroma. This was referred to us after surgical resection and recurrence in a young patient. And next slide will show you the regression of the tumor in basal angiophyma. Next, please. In gliomas, oligodendroglioma is one which is very good response to radiation. So this, as you can see in this case. Next. Pilocytic astrocytoma can also be treated in deep-seated locations with the radiation. Next. Yes, next.
टेस्ट असां कराईसीं हिनजी त उहा ई माना काफ़ी आहे
नेगेटिव आई आहे वो सही आई आहे
माना हाणे कोई हेठां ॿारी में त ख़तरो न आहे न
Next. Case of hypothalamic glioma we will discuss next. Clival chordoma, a very resistant tumor. But in this case, we get a very good response, a regression from 12 to 7 cc's, and then further regression is occurring in clival chordoma. Next, please. This is just 3D dimension. We are showing that over a period of time, the regression is occurring in the tumor. Next, please. The grade 2 astrocytomas, which we can only see in T2. These are very difficult to treat in the insular region. But if we give radiation over a period of time, we can see the T2 intensity is decreasing over time. And there are many patients which we are our follow-up after radiation treatment. Next, please. This was a case of oligodendroglioma with other views. Next, please. Another case, a very large one, which we treated with the multiple fractions, and you can see the regression. Even the midline shift, the ventricles have achieved their shape again, and the midline shift is gone. This was a grade 2 astrocytoma. Next, please. Another case of grade 2 astrocytoma treated with radiation with a very good response. Next, please. Brainstem glioma in adults. We have different results in PEDS. Another in PEDS is still very resistant. We have no answer to that. Sometimes we get an initial result, but again recurs. But in adults, brainstem gliomas, we have patients for more than 2-3 years in our follow-up, and with regression occurring in the tumor. Next, please. This you can see the brainstem glioma before radiation and after radiation, the regression is achieved. Next, please. The same patient with the sagittal view, or the regression occurring over a period of time, the swelling of the brainstem is gone in the latest images. Next, please. Another case of brainstem glioma, 22-year-old. Next, please. Yeah, the regression in T2 intensity occurring. Next, please. The sagittal view of the same patient, you can see the regression in T2 intensity. Next, please. Multiple METs. Before gamma knife, radiosurgery, it was said that if the disease has reached the brain, it is the end of the treatment for these patients. But now it is actually the primary disease which kills the patient, not the brain mets, because the brain mets, they respond very well to radiation treatment with the radiosurgery, and we can treat multiple mets at multiple times in the same patient. And the cognitive, there is no decline in cognition, as you see in the whole brain radiation, in which if the patient survives for 1 year, it has been gone down in cognition. But with the radiosurgical treatments done multiple times, the cognition is not affected. Next, please. The brain mets disappearing after radiation. It takes about 6 weeks for the brain met to respond. Next, please. Multiple mets in the posterior fossa. Next, please. Which another posterior fossa mets, which at 3 months show a good resolution. Next, please. The orbital lesions like uveal melanoma, that can also be treated with the gamma knife. Next, please. Now we come to the AVM malformation. You see this is the AVM, the feeding arteries, the draining veins, the typical nidus there is. So next, please. This nidus is actually our target. We don't have to touch any feeding artery, any draining vein, just the nidus, because it is a nidus where the abnormal vessels are. And there is no brain tissue involved inside the nidus. So it's a very good target for radiation. Next, please. This is a patient in deep-seated AVM, which we treated. This is at 1 year. And this is what second year you see good resolution of the nidus, obliteration of the nidus. Next, please. Another deep-seated lesion, which is sagittal view. You can see all clearance of the nidus. Next, please. Eloquent area, AVM. See very good result in a child. Next, please. Cavernomas in deep-seated location, like in this brainstem, they respond very well, and the further bleeding, the risk of further bleeding is reduced with the radiosurgery. Next, please. This was an interesting case, posterior fossa AVM, which actually the patient presented with trigeminal neuralgia because of the effect of this AVM on the trigeminal nerve. So we treated only the AVM. The AVM regressed. This pain of trigeminal neuralgia also gone. Next, please. Trigeminal neuralgia per se, we have treated more than 200 cases here at Dow in the last 2-3 years. And this is the target which we do, and we give them 90 gray in a single session and frame-based treatment, and the results are very good. Next, please. Functional targets are a separate indication, which a long time are discussing that. But just to show that was an essential tremor, we targeted VIM. You can see the result after radiation, the target we have been achieved, and clinically also there is tremors were reduced. Next, please. Next, please. Previous slide. So what you expect that you're giving a high dose in an eloquent area, there can be initial edematous reaction, which we usually give steroids to our patients for a few weeks to decrease these reactions. But you can always expect and have to treat it prophylactically. So about 5 to 10% cases, they become more, and you need a higher dose, sometimes intravenous steroids. If the lesion you have treated is large enough, in that case, also we give prophylactic steroids. Next, please. Like in this case, especially in AVM, when you give a higher dose, you see this kind of perilesional reaction. Like this was in MRI after 6 months, but nothing to be afraid of if you give steroids to this. Next slide, please. This all edema is gone. Also, the obliteration of AVM has occurred, and patient is then normal. Next, please. So, in last 3 decades, the radiosurgery has been used as a neurosurgical instrument and has changed the landscape of neurosciences and neuro-oncology. It gives a safe, accurate, and reliable treatment option. And it's continuously, there is investigation and innovation occurring in this field. Thank you. Thank you.
Sir, we are very thankful to you for spending your precious time with us and sharing knowledge, high quality knowledge. With this, today's session is completed. If anybody has any question from sir, he can raise hand. I can unmute him, so we can ask any question which somebody wanted to. We have more lectures with sir, and with this, I'm telling this another thing, that in the next month, inshallah, we will be doing a radio surgery workshop with sir, and afterwards in April we are planning for a mini fellowship, which the candidates will rotate for 6 weeks in the with at the Doha International OJA, and then for the Stereotactic at Lahore. So both will be doing. Both centers will do simultaneously. This two candidates will be at Lahore and two will be at Karachi, and then afterwards will be shifted back. Sir, so there is a question from Dr. Junaid Nawaz. What is the cost of this procedure?
Yeah, at Dow Oja campus, the dose for a usual patient is the sorry the cost for a usual patient is about 3 lakhs, right? But if the patient is non-affording, we have other options for them. So we don't refuse any treatment just because of the shortage of finances. So you if you have any patient, just write down to us, and we will help that patient. And the health card also from KPK and Balochistan also is available at our center.
This is wonderful. Any other question? So I think there is no question. Thank you so much, sir. Thank you so much for your valuable time. Inshallah, sir, we will meet you soon. Jazakallah. Thank you so much.
Allah Hafiz.
Allah Hafiz, sir.